everyone. We'll get started. Today is a very interesting debate between two of our fellows, Mon and Amon. They will be talking about essentially nature versus nurture, CAC or genetics for risk stratification in cardiac disease. They are kindly mentored by Erica Spatz and Arya Mani, who will provide conclusion remarks after 15 minutes off doc by both the fellows. So with that, I'll get Amon to get started, and hopefully this is going to be a contentious yet civilized debate.
Hello, I'm assuming everyone can hear me. My name is Ahimen, and welcome to our first debate. This is the preventive cardiology debate. You might not see many more of it. And Man and I will be, talking about carcogenetics. Obviously, I'm going to be talking in favor of CAC in the primary prevention setting. So this is my disclosure slide, which is also my gratitude slide. I'm a fellow. I have no financial disclosures relevant to this debate, but I have worked with two of the most popular people who have advanced much of what we know about CAC scoring and its utility. Dr. Agustin and Dr. Coronary, both of whom I worked with when I was in Miami, Florida, and I'm really, really grateful to them, especially Dr. Nasir, who can't be here today, but whose idea it was to debate CAC versus genetics. I'm also really, really grateful to Dr. Spatz, who I called upon on such very short notice, and who's here today also supporting CAC with me. So let's start out with a theoretical case of a 45-year-old gentleman, an African-American man, who comes into your office. He has a history of hypertension, which is treated, and his measured blood pressure is 128/78. His total cholesterol is 187, his HDL is 44, LDL is 119. He's not diabetic, he does not smoke, he's not on a statin, and he's not on aspirin at the moment. But his father had a myocardial infarction at the age of 53. His borderline risk, which is between 5 and 7.5 by the pooled cohort equation, which is also known as the AHCC, AHA, ASCVD risk score. But his lifetime risk, kind of points out to 50%. And so he has a lot of questions. He's like, what's my real risk? What's this 50%? I live a really healthy lifestyle. I exercise. I eat a plant-based diet. I don't smoke. Why is my risk so high? I'm only 45. Why are you telling me I'm going to be on statins for the rest of my life? And then, he knows that I'm going to tell him to go get a calcium score. And he says, Doc, I know you're going to say, go and do your CAC. However, I have a family history. Are you sure I shouldn't just go and get genetic testing done and know my genetic risk? So you tell him to calm down. And so I want to talk a little bit, spend a few seconds on, the gene-environment interaction in the development of atherosclerosis. We know that the atherosclerosis is a confluence or a convergence of your genetic risk and of your environmental risk, and that includes your lifestyle and all. And this is in non-monogenic CAD. Obviously, in people who have monogenic syndromes, that's a different deal entirely. But as time goes, atherosclerosis builds up and soon becomes visible and we can actually see that with CT scans as CAC. So you can say CAC is a visual expression of the confluence of both your genetic risk and your environmental risk. So why CAC? Well, one, CAC predicts cardiovascular outcomes. As we know, there is been this big data set called MESA, and Detrano and et al. Were one of the first to publish in New England Journal of Medicine that over 5 years, there was a dose-response association between your coronary artery calcium score and mortality, such that if you have severe CAC, that means your CAC is above 400 thereabout, your risk of mortality over that 5-year period was 10 to 12 times greater than if you had no coronary calcium. And it's the same with the Heinz-Nixdorf recall study, which is for about 5,000 participants from Germany. And they pretty much were showing the same thing. But CAC is not just restricted to certain populations. You see the same dose-response relationships across all populations here. And the box I have highlighted in red over here is that of blacks. And you see it's the same, pretty much the same. If you have high CAC, your risk of mortality is still very high, regardless of your race or your age, as shown in CARDIA. And the CARDIA study looked at younger individuals. And there's the bioimage study, which has also looked at older individuals, and we're still seeing the same thing. So CAC predicts cardiovascular outcomes across all populations. But predicting outcomes is not enough. The risk scores also do that. But CAC not just predicts outcomes, it improves risk stratification. And this study was from Yeboah and colleagues, published from the MESA data set in JAMA 2012. And what they did was something really interesting. They added several other risk markers to the Framingham risk score, and they wanted to see which one gives the greatest risk improvement in classification, as measured by the AUROC values, which is the area under the receiver operator characteristic curve. And addition of CAC to a Framingham risk score proved to be that which had the most value with reclassification. And I don't have the net classification indices up here, but that value was also higher than if you added family history to a Framingham risk score. And so I think that of everything about CAC, its greatest value is in its ability to be a durable negative risk factor. I know, most of us as healthcare providers are taught to look for risk. A person has hypertension, we say, okay, you're at risk for a stroke, or a person has diabetes, we say you're at risk for peripheral arterial disease. And then the idea is to try and mitigate that risk, try and treat that risk, which is the old paradigm. And in this paper by Dr. Blaha and Dr. Nasir, they kind of talk about the concept of a negative risk factor. And there are not many durable negative risk factors, one in which you can say if it is not there, you're kind of confident that your risk is reduced, and instead of trying to treat, you can instead modify lifestyle and weight. However, CAC has proved to be a durable negative risk factor. And you will see me talk about zero CAC, or the power of zero, from here on out. So to buttress my point, there's been a study by Dr. Nasir, published in 2015, again in JACC, and you can see that this is from the pooled cohort equation. People who were at borderline risk, 5 to 7.5%, or intermediate groups who, by the 2013 guidelines, would have been either considered for statin or recommended statins, he showed that over 10 years, first of all, that more than half of those who were borderline had a CAC of 0. Their mortality was much less than 5% over 10 years, and that almost half of those who were intermediate had a risk of less than 5%, also those who were CAC of 0. And so the point here was that a CAC of 0 was predictive of low incidence of outcomes. But CAC of 0 is not the same as minimal CAC, and that's what this slide is trying to show. So in this very large data set, 44,000 people or more, Dr. Blaha and colleagues showed that if your CAC was 0, your risk over 10 years was about 0.87. But if your CAC was somewhere between 1 and 10, that risk was 1.92. Now that may seem like a low risk over 10 years, but it's still double the risk compared to a CAC of 0. So how does that compare if you have a family history like our patient or our theoretical patient has? Well, if our patient has a CAC of 0, as shown in this slide, he will have well below 5% risk over 10 years. And that's huge. So what makes CAC such a great public health or population health tool? Well, one, it's safe. The radiation dose is about 1 millisievert. Think about the mammograms, which are somewhere between 0.4 and 0.8. And so if you have 3, you definitely have had more radiation than having a coronary artery calcium score done. It's reproducible. It's quick. It takes about 10 to 15 minutes. So pretty much you're in and out. And it's been highly correlated with atherosclerotic plaque burden. It's inexpensive, and we're working on that, trying to get insurance companies and Medicaid and Medicare to cover that. But typical out-of-pocket cost run in most places is about $100, and the data stays is still about $50 to $350 in general. But there's more. CAC has not been associated with increased downstream medical testing or resource utilization, and in fact has been shown to be efficient in utilization of resources, as we see in the Eisner study, which was a randomized trial of over 2,000 people to a CAC screening group or a no CAC scanning group. And then, there have been studies looking at benefits to patients and their providers of just showing patients what their coronary calcium looks like. And in this study by Oraxai and colleagues, which is actually one of many, people who had significant coronary calcium who were shown that they had calcification in their blood vessels tended to start aspirin, they improved their diet, and they increased exercise. So how does CAC compare with the polygenic risk score, which I know Man is going to be talking about? Well, there are no head-to-head studies, I must say, so no studies have compared them. But I went around scavenging for some data, and I found Severance had looked at coronary calcium prevalences in persons who had low genetic risk. So our patient is 45. If, based on Severance's data, his likelihood of having CAC is at about 16%, based on this, and that's the red that I highlighted here. Now, there are no head-to-head comparisons, but I looked at the Amit Kara paper, which I think Man is going to talk about, and when you look at low genetic risk scores there, the prevalence in ARIC was 5%. The incidence of cardiovascular outcomes was 5% in ARIC, comparing to MESA, which was 1.8%. And again, there's a difference in the age of about 10 years. ARIC participants were older. But when you looked at a high genetic risk score, the prevalence of the incidence of outcomes was 10% over 10 years, compared to if your CAP was above 100 or above 300 in MESA, where it was 14 and 26% respectively. And so that kind of gives you an idea that, CAC is probably better at risk stratification. This was taken from a meta-analysis where people had been, basically they were looking at the impact of communicating genetic risk. So you do a genetic score, you tell people what their genetic risk, does it have any influence on lifestyle? And the answer is no. There was no statistical significant difference in smoking cessation or medication use or in change of diet or physical activity. And then finally, my last slide on genetic risk basically was that, the genetic score has not been consistently validated in all populations. And so in Africans and in Latin Americans, in this particular genetic score from the Interheart study, they showed that there was really no relationship between the genetic risk score and the myocardial infarctions. Raises the question, is the genetic risk score really for everyone? So back to our 45-year-old patient who has a 7% 10-year risk. I would ask you to ask yourself, would you be more reassured by a low genetic risk score or by the absence of coronary calcium? And which one do you think will spur you or even the patient to be more aggressive? A high genetic risk score or a coronary calcium? In closing, I'd like to say thanks to my wife and child who were just here. I think they just stepped out. But for coming to give me support. Thank you. Yes.
Thanks. Good morning, everyone. Thank you all for being here today. I'm very glad to be here debating this topic. And many thanks to Dr. Mani for his mentorship. I have no disclosures. So today I'm going to talk about genetics as a very powerful tool for cardiovascular risk stratification and how it could play in our clinical practice. So here we're showing a Google Map-like cartoon of all the layers of information and the risk factors that contribute to health and disease. And while Ahmed has spent the last 20 minutes talking about imaging markers, I'm going to spend the rest of the presentation talking about genetics and how that might impact risk stratification. But there's also many other pieces of the puzzle, like the transcriptome, the epigenome, microbiome that are not accounted for, and the exposome refers to the environment, which mainly contributes to the traditional risk factors. So in brief, we're going to go over the heritability of coronary artery disease and then review the development of polygenic risk scores, the performance of polygenic risk scores, and compare that to calcium scores. Coronary artery disease, as we all know, is a very complex disease. The heritability is estimated at 40 to 60%. And we also know that patients who have a very strong family history of premature coronary artery disease have an increased risk by up to 3.5-fold of developing CAD themselves. Many of the investigations that aim to uncover the genetic basis of this association or risk have focused on family-based studies, and those were the earlier investigations. We know this is some of the genes here, but there are many others. So loss of functional mutations, for example, in the LDL receptor, that increase the LDL levels and contribute to premature CAD, along with the gain of function mutations in PCSK9, loss of function mutations in DYRK1B, contribute to metabolic syndrome, mutations in lamin A, PPAR gamma, and many other genes contribute to hereditary lipodystrophies, which many of those actually contribute to an autosomal dominant pattern of inheritance with high penetrance. However, if you look at a population of patients with early onset myocardial infarction, you only have 2 out of 100 who actually will have identifiable mutations of monogenic inheritance. And most of those mutations tend to occur in pathways of lipid metabolism, and on average will increase your risk for early onset myocardial infarction by about 4-fold. So the quest to look at the genetic architecture of CAD shifted towards looking at mutations with smaller effects, smaller size that are more common, that would additively contribute to the risk of CAD in the population. And this is an important slide to show, just to emphasize the point that there is many variations, many point variations in genes, and the more common variations tend to have less effect on function. So here the phenotype we're looking at is cholesterol levels, and allele frequencies that are more common are less likely to contribute to have any functional significance that will contribute to the phenotype, such as cholesterol levels, whereas the rare mutations tend to have much more drastic effect, and they're naturally selected against. So genome-wide association studies were the approach to look at common variants with small additive effects. And the beauty of genome-wide association studies is that they're non-biased screens of the whole genome. So since 2007, there has been more than 10 GWAS studies for CAD. There has been over 1 million participants, and those have identified more than 150 loci for CAD. The basis of genome-wide association studies is we're not genotyping the entire 3 billion base pairs in the genome. It's looking at common SNPs and those polymorphisms or delete variants usually define a segment of DNA that contains many other polymorphisms that are in linkage disequilibrium. So those genome-wide association studies are looking for statistical association between those common variants with the disease in cases versus controls. And most of the time, those SNPs themselves are falling in non-coding regions, and they're rarely ever associated with actual direct molecular functional effect. But the likelihood is that they're linked to rare mutations within that DNA segment that actually will increase your risk for conferring the phenotype. So again, out of the millions of polymorphisms looked at in genome-wide association studies, it has been a very satisfying endeavor looking at variation and connecting them to function. Only a handful of actual polymorphisms were linked directly to function. However, a lot of insight has been generated from those GWAS studies. Many of those loci actually fall within pathways of lipid metabolism, thrombosis, insulin resistance, inflammation, and that helped also initiate a lot of investigations on those pathways. Genome-wide association studies also were the basis for development of the polygenic risk score, which relies on using many variants to come up with a genomic score of risk for CAD. And I'll explain that. I'll try to explain it more next slides. So one of the more prominent studies for genetic risk scores used genome-wide association data and all the variants from multiple genome-wide association studies. And they derived 31 different scores for coronary artery disease. And then used the biobank to validate and test the best performing score. And a few words on the biobank that's used in this study. It's the UK biobank, which contains 500,000 patients. 98% of them were European ancestry. And in this biobank, genetic and clinical data was collected on all patients with a follow-up of about 6 years. About 10,000 of them had CAD diagnosed before recruitment, and more than 12,000 developed CAD during the study. So out of those 31 scores, one of them was validated to be the best in about 120,000 patients from that biobank, and then it was tested in about the remaining 300,000 patients. And this risk score, GPS-CAD, actually contains 6 million variants, which additively attributed to that, to this scoring that I'm showing here. So GPS-CAD identified 8% of the population, the general population, representative of general population, that's at risk of threefold increased risk of CAD. And obviously, the higher the threshold, you can even narrow down to people at super high risk, more than fivefold increased risk that include 0.5% of the population. So here you also can see that the polygenic risk score is normally distributed. In terms of patients with confirmed CAD versus controls, the median score was obviously higher in patients with CAD, around 70th percentile versus 50th percentile. And the prevalence of CAD increased dramatically towards the right tail end of the distribution, where you had 11% prevalence of CAD in patients with the highest score compared to 0.8% patients with the lowest score. So that same score was studied in another group of patients, around 2,000 patients with early onset myocardial infarction, comparing them to 3,000 or 3,700 controls. Those were all US, based in the US, and were composed of 4 racial subgroups. The mean age of myocardial infarction was 48 years, and all of those patients underwent genome sequencing for rare mutations and also to actually come up with the calculation for their genetic risk score. And we can see that whereas only 2% of patients had identifiable monogenic mutations, more than about 17% harbored a very high polygenic risk score, which increased their risk for CAD or early onset myocardial infarction by 3.7-fold, which is very similar to the risk conferred by non-monogenic mutations. And in that same study, looking at the LDL cholesterol level and 4 different groups of patients, all of whom had early onset myocardial infarction, we can see that patients who had the high polygenic risk score, their LDL was very comparable to those who had low genetic risk score. Whereas patients who had familial hypercholesterolemia mutations, their LDL level was over around 200. For patients who harbored both high polygenic risk score and monogenic mutations, their LDL levels were even higher than that. A few words about ethnicity, and there is no question that those risk scores are much more applicable for Caucasians, whites, and patients of European ancestry, because that's where the data came from and that's where they were validated. In this same study, which included the 4 racial subgroups, you can see that white and Hispanic polygenic risk scores were pretty close, but the African Americans tended to have lower polygenic risk scores and Asians had higher risk scores. So that by itself obviously throws off the calculations and the estimates. Normalizing using principal component analysis for control for ethnicity can be employed, but even then the predictability of the score is much more valid in patients with white ancestry compared to blacks or Hispanics or Asians. And this is also another important slide to show from another study, they used a different score also, which included several million variants. Also, this was applied on the UK Biobank patients. And we can see that the genetic risk score has a greater association with CAD than any of the single traditional risk factors, such as smoking, diabetes, and even family history. The genetic risk score actually outperformed family history in terms of prediction. And obviously, if you add those scores and the traditional risk factors, you get a much better assessment of the actual patient risk. And that's shown at the end here. Goes without saying, genetic score doesn't change with time, and it has the power of detecting risk very early on and giving the chance to intervene on patients who are not included in the current scoring systems, and also can detect with even more studies looking at prospective studies, we can look at the onset of disease in patients with certain risk scores. In terms of lifestyle, just a few words. So here we're looking at 3 studies with more than 40,000 participants that looked at genetic risk and lifestyle. So in each of the studies, we have the patients with low genetic risk, intermediate, and high, and also with unfavorable lifestyle colored in red, and favorable lifestyle colored in blue. And you can see that with worse lifestyle, you have higher risk of coronary artery disease. Also with higher genetic risk score, you have higher risk of events. And this study looked at the impact of favorable lifestyle changes and how that affects risk. And it actually had among patients with very high risk scores, the favorable lifestyle was associated with 50% reduction in CAD risk factors. In terms of medications, here we're looking at data from a randomized controlled trial for primary prevention with statin therapy. And we can see that patients with high genetic risk score benefit more from statins than those with low genetic risk scores, and probably because they have higher burden of subclinical atherosclerosis. Although again, based on what I showed you before, it doesn't mean they had higher LDL levels. Other studies have associated the risk score with the carotid plaque burden, with calcium scores, and the optimal age to obtain a coronary calcium scan. So back to the patient. If you have a 45-year-old with intermediate risk for CAD based on the traditional risk factors, a high polygenic risk score would actually sway you towards aggressive primary prevention, even if the calcium score is 0, because once you have calcium, the patient already has the disease, the horse is out of the barn, and with the genetics, you can actually mitigate the risk. You're looking at a different set of information that could help mitigate the risk of disease. And this is the final summary slide. Just some of the factors that distinguish the two. There is no retesting needed with polygenic risk score. Calcium score, you have to retest every few years. It's very dynamic, it changes. With polygenic risk scores, you're more likely to capture a rare pathophysiology, not necessarily just calcific atherosclerosis contributing to CAD, but other pathophysiologic mechanisms with rare mutations as well. And genetics itself can be applied to many other diseases. So if you genotype someone or sequence them, the same score can be used to predict risk of atrial fibrillation, stroke, et cetera. And those studies are still in progress. In terms of validation across races, not so much with polygenic score, just because of the current architecture of the genetic databases, not very inclusive. And the prediction of CAD and associated outcomes, both of them do that. And in combination, they probably, along with the traditional risk factors, will give us a much high resolution picture of risk and contribute to better primary prevention strategies. And they have similar costs.
Presenting a lot of data. While I'm just getting set up, I have a disclosure. So in 2009, I wrote an article in Circulation with Joe Ross called Misshaping, and shape is in capital letters, public policy. And it was in response to a bill that was passed in Texas called the Heart Attack Prevention Bill. And this mandated that every person over the age of 45 have a coronary artery calcium score done every 5 years. So there's a lot of dogma in this area. And my argument was that, number one, we just don't have data to put that forth into a bill, and what about all the other things that we know that work, that save lives? And so since then,
Just press laptop on the screen up there.
So since then, we've become a lot more nuanced in our risk stratification, but I think that we're still a little bit lacking. And so hopefully I can try to maybe bring together some concepts. So one is that, we really turned to the ASCVD risk score, especially in 2013, where it became the primary way that we risk stratify patients. And we put people into this, algorithm, and it pops up in our Epic screens. And you guys know all the factors that went into it. And I would say it's an advancement because prior to that, we had the Framingham risk score, and the Framingham risk score significantly underestimated risk in women, especially in younger people. It was derived in the Framingham cohort, a predominantly white male Northeastern population, whereas the ASCVD pooled cohort equation, again, pools, cohorts, much more diverse cohorts. So there's a lot more credence in this 10-year risk score, but still it kind of fails us in many ways, right? We can categorize people into low, intermediate, and high risk and see who needs a statin, but it's very one-dimensional. And this is sort of my interpretation of what it looks like when I go into the patient's room, because I already know, I've already derived the score, and I'm just basically telling them, I put your numbers into a calculator. Here's what you got. Here's what, here's what comes next. So, how do we advance this? How do we move towards more of a paradigm of biology versus biography? Taking into account family history. And family history is our genes. Is there any premature coronary artery disease? But it's also the shared lifestyle aspects that run within families that people are very sure to tell you. My dad died of a heart attack early, but he also smoked and was overweight, and that's not me, right? So how do we reconcile those two? Women are eager to tell me about their pregnancy experiences. Did they have preeclampsia? What's happening with menopause? And then sort of the other things up here, stress and diet and weight and exercise. How do we combine that into our risk score? Because the ASCVD risk score does not take into account all of those biographical things that we don't derive from the EPIC EHR. So what I have found to be my own personal challenges in this field of risk stratification is, what is a person's true risk? And how do additional data points about a person's biology, their genetics, but also their biography, like their stress levels, modify that risk? Is one factor disproportionately impacting risk? So I have a really healthy person in front of me in terms of dietary and exercise, but they carry a really high burden of premature disease in their family. Which one is winning out there? And what kinds of information may be helpful for us, both the patient and the clinician, in defining next steps? So here's a few thoughts. So calcium scores, I have come full circle. I do use calcium scores. That's my other disclosure. So I'm not against calcium scores, but I'm just more for the strategic use of calcium scores. And calcium scores do help better risk stratify among people with traditional risk factors. So on the left side are people with 0 risk factors, and on the right side are more than 2 risk factors. And green is a calcium score of 0. And we can see that even in people who have 0 risk factors, there are some who have calcium scores that are greater than 400, right? Totally paradoxical to what we thought. And similarly, in the greater than 2 risk factor category, about 25 to 30% of people have 0 calcium. So we don't, our traditional risk factors of cholesterol and hypertension sometimes may misguide us. This is another study that is coming from MESA, and here we're looking at ASCVD risk and coronary artery calcium. And sorry that this is so small, but basically on the left-hand side is a negative family history, and on the right-hand side is a positive family history of premature coronary artery disease in a first-degree relative. And there again, you can see that there's heterogeneity in calcium scores. Now, if we believe the data that Ehimen presented that calcium scores are related to risk, we may want to get a calcium score in people who have a family history, because we may be able to better risk stratify them to say, is this likely that you've inherited some premature atherosclerotic disease that may portend a higher risk for future cardiovascular disease. And sort of the third area that I'd like to just hit on is this stress response in coronary artery disease, right? We don't have any biological imprints of stress that we can use at the bedside, but there is some early data that shows that coronary artery calcium may be capturing these sort of less numerical, less quantifiable aspects that we know influence cardiovascular risk, like stress. So in this study, they showed that cortisol response to actual stressors was independently predictive, a 27% increased risk of having calciums in your heart arteries. So the calcium data is consistent in terms of showing us that it can help to predict future risk. These are just some of the studies that have looked at calcium, anywhere from the MESA study, which you will hear a ton about, down to the Women's Health Initiative. It does work. One of the slides that that Man showed you is the use of polygenic risk scores in both a control and a case population. And you can see that the polygenic risk score is more prominent in the cases, but there's a lot of overlap. These are the box and whisker plots. So the median polygenic risk score is higher in cases of people with coronary artery disease, but there's still a ton of heterogeneity, and those box and whisker plots very much overlap. And this study, which was also shown by Men, that was in the New England Journal of Medicine by Amit Kara, shows that we can better risk stratify people if we take into account lifestyle considerations. So in this case, they looked at genetic risk, but they looked at it using 4 additional lifestyle factors: weight, diet, exercise, and one other one. I forget what it was. But basically, they're showing, again, heterogeneity. And they're showing that if you have a high genetic risk score, but you had a healthy lifestyle, there was a much less likelihood of going on to develop cardiovascular disease. So with that said, I think it's important that we take into account our biology and our biography. I think, we need to have more nuanced conversations of when you might consider a calcium score. And then we can put them into our calculators, but hopefully have those calculators be built with more biology and biography. And ultimately, I think we need this sort of integrated approach to precision medicine. This comes from Rob Califf, which shows that genomics and environment and and then the clinical data that we get from our EHR is hugely important in building up to that sort of precision-based approach to prevention.
So thanks everyone for a great debate. I actually rather not take on 2 very, very different opponents today, especially when one of them appears as an orphan fellow today. Actually I'm going to try to actually see the pros and cons of both approach, and I talk about misconception in the area, and see what we have to do and what we have as a task and what we actually can learn. And finally, if I have time, to talk about the conclusion. I don't know if this one is mine because it's all okay. And the point I want to make actually, first of all, is that when you talk about genes, the size matters. And many of you are familiar with this disease, the muscular dystrophy. When you are born with it, no matter how much you change your environment, you live with it. And this is unfortunate. But there's much more than changing your diet is needed to help this issue. Oh, after all, we know actually the genes are so important that we have much more genes like Einstein compared to the yeast. But later we understood actually there are much more genes actually in fleas than in ourselves, suggesting that the genes are not everything there. And actually, we know that genes kind of make your proteins, but the proteins are modified, and they can be expressed at different levels. And some of you are much more muscular than I am here, despite having exactly probably the same sequence in my genetic proteins. And that is how they modify. Actually, each cell probably expresses about 14,000 genes. 10 times more are phosphorylated, actually. So this matters what happens. And you see, actually, if you put your patient in the ICU, you're going to come very much similar to your muscular dystrophy patient after you left them for 3, 4, 5 months. Which means that actually brings me back to the precision medicine. This disease is caused by something else than this disease. Now, genes are really so important. And this is actually the Drosophila on top, and these are Hox genes. And Hox genes, they determine where is your antenna, where is your foreleg, where is your hind leg, where is your wings. And interestingly, they are all ordered on the same chromosome exactly the way they appear on the body. But this is not only the Drosophila. Human, exactly the same thing. The Hox gene in us is exactly the order actually our legs and hands and arms are formed. So some genes are really, really important. You cannot play with them. And if you have a mutation, actually you die most of the time, but if some patients have a minor mutations, they get abnormalities in the leg. But also, you guys remember from thalidomide. The mother who took thalidomide, the children were born also with similar defects. So drug and environment also can cause same phenotype. Precision medicine. Now, the environment actually can affect our genome. Many of you know about the CRISPR-Cas technique. We use that for kind of modifying the genes. This CRISPR-Cas actually came from the virus that actually invaded the genome of the bacteria. And then bacteria to use that as a, to come and actually identify the target virus genome and cut it out. Also, our intron, the part that is not coding is full of transposons. These transposons are bacterial elements that incorporated into our genome. So they're actually jumping elements. And most of the time they don't do anything bad, but sometimes actually they do bad things. They fall into the regulatory region and they may affect your genome. So environment, genome, both have effect, and I agree with that. So that's why actually when we kind of laughed at Lamarck, who once said, because giraffe has a long neck because it has to reach the leaves, and we said, Darwin is correct. We now know that some of the things that Lamarck said is also not absolutely incorrect. So you should take things with a grain of salt. For example, not to accept everything that Darwin said, although most of the time it was correct. For example, he used to comb over his hair to cover his kind of bald spot, and I don't do that. I don't think it's the right thing to do. But let's go and say about the genes and their kind of effecting in our life and disease. The very first genes actually Mohan mentioned are monogenic disorder. He mentioned LDL receptor, and these were actually genes that happen in the family, frequent. And the way we discovered them, we look at the several regions of the genome that were polymorphic, and we hope that that polymorphism is very close to the gene mutation. And then when we identify them, I don't have any pointer, unfortunately. When we identify them, we kind of know where to look in the chromosome and find the mutation. Good. Then, we identify several gene mutations, and I have to say that when I presented to you the muscular dystrophy, many of you may thought, okay, these are very early onset disease. This is genes with a large effect. But what about the adult disease? I mean, adult disease should not have that kind of thing. This takes 40 years for me to get a coronary artery disease, or 50, 60 years. The reality is that actually there are genes that actually have large effect. But they come later because your body fought with those mutations. This is a mutation in 3 most common genes of the long QT syndrome. And as you see, they are going to get event. No matter how much you change the environment, people with long QT are going to get disease. And the reason actually they don't get disease until later is that because our body has a defense system, chaperones, that actually keeps and degrades the proteins that are mutated. But with the long life, suddenly they're going to keep up with us and we get the disease, such as here, the drug actually showing that the abnormal protein, as in a dot that he aggregated, suddenly by giving a drug, went to the surface, and the Western blot shows actually the plasma membrane appeared there. So let me skip that because of the sake of time, come to coronary artery disease. So the disease I showed you was a very rare disease, right? Let me go back again and show you that this is a long QT syndrome, and this, we are going to talk about coronary artery disease. In long QT syndrome, what's the rate of long QT syndrome? Probably 1 to 100,000. If an individual here has the mutation that you identify, very much chance that everybody else has the same. Because how can a family be unlucky that each individual has different mutations causing such a rare disease, right? Unfortunately, coronary disease is very different. And in coronary artery disease, what happens is that each individual of you here, sitting here, if I sequence you for the coding region, have 50 actually variants that are unique to you. So what is the chance that everybody else in this family is going to have the same mutation causing disease? Well, the problem is that some of them are going to have mutation number 7, some of them mutation number 2. That can even change. Some of the different ones are going to get mutation number 6, some mutation number 4. You're never going to be able actually to identify if there is a one single mutation in this family by this technique. They're not sharing it. This is a common disease. Some of them have disease because of other mutations. Now, if you come to other condition that both parents are affected, the situation is even worse because you have each of them bringing 50 new mutations, and as a result, you're going to have a possibility, a very large possibility, that they can combine and cause disease. So we have a problem with the technique to identify rare variants. To overcome that, my colleagues actually decided to go with GWAS studies. They said, well, why don't we actually study instead of one single family in which few of them are going to destroy my statistic, a large population. And I'm going to look at about 1 million base pair from 3 billion base pair in the genome and see which one is more common in the cases versus control. So please pay attention that this is a complete different look at the problem. Now you're looking at common variants. You're not looking at the one that you were not able to discover because of the complexity. You're looking at variants that actually very much different in this population. But also to have a good statistical power, you have to look at variants that are very common in one group or in a general population. Then you make a Manhattan plot there and you say, okay, this variant, like C4T on the chromosome 11, was much more common in my cases versus controls, and I have a locus. You don't have the gene though, by the way. You have a locus, exactly like linkage. You have a locus, it hopefully is close to your gene that you're looking for. Now, Ayman said that in minorities, we don't have much of a power to show that. That's not true. The reason is that in, let's say, in Africans or a very large population, we have had so many recombinations that that variant is no more close to the gene you're looking for because there have been a lot of during meiosis recombination. So you have to study that specific population. You cannot use the wide GWAS studies for that. But it's still powerful to discover for you common variants. Now, common variants have very small effects. If you look at the effect here, it shows about 1.19, 1.11, Why? Because these are common variants. You and me have it. If you and me had it and didn't get disease, so the effect size is small. So people decided to do polygenic score, meaning that lump sum many of them to see what's the effect. In this study, they divided into 5 quantile, and they showed that if you have a top quintile, you have higher risk. And then they showed actually that if you treat those 5th quintile with a statin, you benefit them. Obviously, you're not going to do that only for the 5th quintile as your patient, because if you look at the studies they looked at, people in yellow box here, they're intermediate polygenic score, there's still benefit. So you cannot kind of say, okay, I'm going to only treat the ones who actually very high polygenic score. And the problem also is the hidden heritability. If you look at them, they only detected fraction of patients had a high polygenic score. So if this table is small, but only 14 people ended up to be in the highest quantile group. So you're actually detecting a little bit of this. And the problem is that with polygenic score, you're looking at the common variants, not a rare variant. This is the study about the, that you showed here about the healthy lifestyle. Yes, that is true, that if you're actually in kind of a highest risk group and have an unhealthy lifestyle, you're actually worse than somebody in an intermediate group. That is true, but it's not true when you look at the entire population here, because you see genetics occasionally in some populations actually determine how you're going to have event or not. And look at that, I've highlighted here. They don't explain to you exactly what's going on here, because polygenic score is different than family history. Family history of coronary artery disease was an imperfect surrogate for genotype-defined risk, meaning that these variants are not the ones that actually show heritability. If I can explain a little bit here, I'll show it here in this slide. Look at this. This is an individual with polygenic score here, down the affected one. He got his variants from both mother and father, and the mother was not affected. What does that mean? It means that you were looking for to see what this guy inherited from the dad, but you didn't find it. You found only some SNPs here that have effect, but they are not explaining the heritability. And that is why in another study that came out showed that if you look at the people with monogenic hyperlipidemia, like LDL receptor mutation, ApoB mutation, that mutation can tell you more about event versus if you measure the polygenic score. Polygenic score alone was not able to actually identify them. However, when they combine polygenic score with Mendelian mutations, there were much more events suggesting that both are helping you to make a decision. So mine actually brought this slide. And I think this was actually a very powerful study by Kara and Katirson team, which finally got the point how to use the polygenic score. What they did 6 million SNPs instead of 100 SNPs. And they looked at different diseases. And they were able to identify about 14% to 17% people who actually are going to have MI as a premature MI. And this was much more greater number than we identified by mutation in LDL receptor, ApoB receptor, suggesting that almost 1/5 of your patients who are going to have premature coronary artery disease can be detected early by polygenic score plus looking for rare variants. So is that nothing to you? I mean, look, I understand that 80% of your patients who are going to get premature ALD, you have no clue what's going to happen, who those people are. But 1/5 of them you can actually detect by polygenic score and rare variant together. Now, if you want to wait for them to have a calcium score of 100, be my guest. But you want to actually detect them much earlier, because once you have the cats out of the barn, it's too late. Calcium scoring when you have 100, you have a disease. Now you can impact, but we want to have impact much earlier. Now, so let me conclude with this slide, see what I suggest we should do. About these people, about 100 people here who are going to get premature coronary disease, right? We are able to polygenic risk score and single gene identify 20% of them, 1/5 of them. If I identify 1/5 of them, more I'm showed on the slide that if you put them on a statin, you bring the risk of these very high risk people to half. So that's great. And you can also do lifestyle modification on those patients, and that would be helpful. But 80% you don't know what to do. And my point about going all over this genetics, somehow complicated, is that we don't know all the answer. We don't know all the mutations causing coronary disease. And because we cannot detect the mutations, single gene mutations or mutations that are or diseases that are oligogenic, doesn't mean there is none there. Your patient may have 2 mutations and I'm unable to find it because my technique is limited. So this 80%, I agree with you, that what we have to do is that first of all, identify disease genes. Second, calcium scoring is great. Other screenings are also important. And then you can put them on statin if they have high calcium scoring and lifestyle modification. I think we have to learn about our limitations and act on it based on what our limitations are. Polygenic score helps, but it's not the complete answer because we don't know the answer completely. We have no polygenic score for minorities either, but doesn't mean they don't help. We should just start doing it. And then gradually identify the disease gene itself, because polygenic score that you introduced today is going to find a marker for a gene that we are, in this population. It's never the same gene itself. Mohan mentioned that when they did a polygenic score, the LDL cholesterol was not different between the one high score and low score. But the polygenic score is sitting beside the LDL receptor, beside the PCSK9. These are among the genes that are identified, which it means to me that the marker is beside the gene but doesn't affect that gene necessarily. A marker could be actually associated with another mutation that even if it's inside your gene, may affect another gene nearby. So it's a lot more work to be done. Obviously, even if you find these variants, how to treat them, how to actually modify the risk is also important. So I think we have to know our limitations, but also the benefit of what we have accomplished. And I agree that calcium scoring has its own place, genetic polygenic risk score its own place. Thank you so much.
So in the interest of time, first of all, I want to thank our 2 fellows and their families for being here. This was wonderful. You did a phenomenal job of organizing a very difficult set of topics, and we were blessed really to have both Erica and Mani take us to the next level. There's so much to do. I would say that we are in the right place to do that work, and so I hope we leave here this morning with that kind of excitement about what we need to do into the future. So thanks.